I would like to invite Dr. Bindu S. Ajith. Madam is a senior and a head of department of glaucoma and cataract at Comtrust, Calicut. Over to you, madam.
Good morning, all. I will go to the topic of fixed drug combination. Now, what do you mean by fixed drug combination? It's defined as a formulation that contains two or more active pharmacologically ingredients combined in a single dosage to form a fixed ratio intended for simultaneous administration to achieve specific therapeutic goal. Now, why do we need this fixed drug combination? As we all know, we have issues with the multiple medications that we start for the glaucoma patients that lead to the poor adherence to the patient, and definitely our patients are on the older age group and they are confused over the regimens, and there is an increased risk of missed doses and higher cumulative cost. And then definitely the most important now is the OSD, and so the preservative exposure becomes a major concern. Now, why the FDC has advantages over the monotherapy? As the number of drugs are instilled are less in a fixed drug combination, the washout effect is not happening there. The local tolerability is more. Convenience of administration is definitely there. Therefore, the compliance is increased and exposure to preservative is less. As we all know, long-term use of topical medication comes with its own complications of hyperemia, tear film instability, stinging, burning sensation, and dry. And all this is mostly attributed to the preservative exposure. And when you multiply the drops, like I keep on adding glaucoma drops, especially that is required for the long-term therapy, you are adding more and more preservative in each bottle of the drop. So, fixed drug combination decreases the ocular exposure to the preservatives. So, when you want to join two drugs, what are the things that we take into consideration is it should be complementary mechanism of action which enhances the overall therapeutic effect, that is pharmacodynamic synergy, and for pharmacokinetic matching, you should not be combining two with an opposite action. So, now we will come to the advantages of the fixed drug combination. Definitely it is to improve the adherence and complications because of the fewer bottle and fewer doses. That is what the studies says. And definitely enhanced therapeutic efficiency because of the complementary mechanism of action. It also has an additive effect and reduce the risk of washout, because when you put one drop and immediately put another drop, it has a washout effect also. Economic and quality of life benefits: fewer prescription refills, lesser pharmacy cost and travel burden. That leads to the improved patient satisfaction and reduced treatment fatigue. Now, what are the limitations and challenges of the fixed drug combination? You lose the dosing flexibility. Single ratio formulation and individualized dose adjustment not possible. Especially when you have a tendency to start a fixed combination, you don't know which of the drug has caused the side effect, or which is effective and which is not effective. That is the confusion that we have when you start with the fixed drug combination. Pharmacologically and formulation challenges are there. Chemical incompatibility. This we have to take into consideration when we are making a fixed drug combination. Adverse effects masking the compliance misinterpretation. Yes, we don't know which of the drug is causing the adverse effect. Patient selection and clinical caution. Now we have especially non-glaucoma patient doctors, they have a tendency to start the combinations first. So, even in a mild to moderate disease or their first line of choice, there is a tendency for starting a fixed line combination, which should be avoided. Like, when only one drug could be enough, we tend to have a combination drug started, which is actually burdening the patient without knowing the effect of single drug. Now, coming to the common FDCs in glaucoma, the most common is the beta blocker and prostaglandin, because it has a combination effect. It combines reduce reduce aqueous production and increase uveous scleral outflow, and the advantage of once daily dosage. And its long-term studies have also proved that it has got a beneficial effect. Beta blockers and carbonic anhydrase inhibitors, another combination that is available, typically dosed twice daily, and beta blocker and alpha agonist, both having a complementary effect. And the other is the alpha agonist and the carbonic anhydrase inhibitors. Now, we do have clinical evidence comparing the studies of fixed drug combinations, studying the efficacy, safety and tolerability, adherence and quality of life, and economic impact. So, these are some of the studies which shows that IOP reduction of more than 30% from baseline was achieved in a fixed combination of latanoprost and timolol. And there are other studies which also proves the combination therapy. Now, these combinations therapy are also intended to see the 24-hour IOP control, which is more because that is the one which is causing progression of glaucoma as the proven things. So, this is also taken into consideration when fixed drug combinations are used. So, fixed drug combination that provides round-the-clock suppression are clinically preferable for progressive diseases too. Now, what are the gaps? We don't have the fixed drugs which have studied the effect on visual field progression. And now, what are the recent advances and future perspectives of the fixed drug combinations? Yes, fixed drug combination has improved the compliance, but further innovation is needed. Now, we also have the triple fixed drug combination with greater IOP reduction, single bottle convenience. And now we are into novel drug delivery systems like the previous speakers told, because it needs a sustained release FDC, hydrogel inserts, punctal plugs, biodegradable implants, subconjunctival and intracameral depots are in the process of coming out, which eliminates daily dosage, improves adherence and reduces the surface toxicity. And the other future perspective is the preservative-free fixed combinations and the nano formulations FDs, which are also to improve the compliance and decrease the side effects of the glaucoma drops. The next generations are the Rho kinase inhibitors and the prostaglandin analogs, and triple FDCs is already there, and fixed combinations with novel targets is on the studies. Now, the other, like all the future prospects are the linking with the AIs, enabling patients for more increasing the compliance, and also that is artificial intelligence into the dropping systems too is what is future now. These are all futures. So, the for practice, it is FDC is the best choice when more than 2 agents are needed and titrated flexibility not critical. Always verify systemic contraindication of both the drugs. Prioritize ocular surface health and simplify, educate and monitor to reinforce adherence at each visit. Thank you.
Thank you, Bindu.